Are there amendments?
Mr. Chairman.
Mr. Boyer?
Mr. Chairman, I have an amendment at the desk. It would be amendment number 47.
Mr. Chairman, reserving a point of order.
The gentlelady from Colorado reserves a point of order. This is the Boyer amendment number 47, did you say?
And yes, Mr. Chairman.
Clerk, and without objection, that amendment will be considered as read. Gentleman is recognized for 2 minutes.
Thank you. My amendment adds value to the preventive health care mechanisms in the bill before us today by providing new pharmaceutical access protections for Medicaid beneficiaries taking antidepressants, antipsychotics, anticonvalescents, immunosuppressants, anti-cancer drugs, and HIV/AIDS drugs. These are the 6 protected classes identified in Medicare and heretofore referred to as the 6 protected classes of drugs. Back in 2005, when the committee worked on the Deficit Reduction Act, we adopted an amendment almost identical to this amendment which I offer today. All of my Democrat colleagues on the committee and 9 of my Republican colleagues supported this amendment. Specifically under my amendment, the State Drug Utilization Review Board must determine, based on standards of practice and the strength of scientific evidence, that limiting access to the 6 protected classes of drugs is not likely to harm patients or increase the overall medical costs. These drug utilization review boards are defined under current law and must have health care professionals who have recognized expertise in appropriate prescribing, drug use review and evaluation, quality assurance, and other matters. The boards must be composed of at least 1/3 practicing physicians and at least 1/3 practicing pharmacists. My amendment additionally ensures that Medicaid patients have access to the medicines that they need if they do not hear back from the drug utilization boards within 24 hours by providing patients with up to a 30-day supply of their needed medications. Currently, Medicare regulations specifically require prescription drug plans to provide access to, quote, all or substantially all, end quote, medicines for treatment of these 6 protected classes. While Medicare beneficiaries are protected, we have no protection for Medicaid beneficiaries. So 3 years ago, that's what I sought to do, was to bring consistency between the 2 programs. I think what we did was the right thing when we adopted this in Medicare Part D. My amendment works to ensure that the same protections are afforded in Medicare beneficiaries are given to Medicaid beneficiaries. Currently, there are virtually no federal protections for Medicaid beneficiaries on how states administer their prior authorization programs. In contrast, Medicare regulations currently require all new drugs in the 6 protected classes to be reviewed by pharmacy and therapeutic committees. These committees, like the drug utilization review boards that I described earlier, are required to be composed of practicing physicians and practicing pharmacists who incorporate the best philosophies when determining whether to approve the drugs. So to illustrate...
Gentleman's time has expired. You want to just conclude?
Yes, I will. My amendment, Mr. Chairman, I've been told is really at a no-cost score. It does not prohibit prior authorization. It merely requires Medicaid programs to examine the best science and medical literature in making these decisions. I seek continuity, consistency, and good patient health outcomes by bringing these 2 programs together, Mr. Chairman.
Mr. Chairman, I withdraw my reservation.
The gentlelady from Colorado withdraws her reservations. The chairman recognizes himself for 2 minutes. I supported the gentleman when he offered this amendment. I'm very sympathetic to what you're trying to accomplish. My concern is that this may have a cost impact, and we don't know what that cost impact would be if we adopted the amendment as a change in the Medicaid program here in their pharmaceutical area. And it also gets complicated because Medicaid has a best price provision, and I don't know how that would impact that particular provision. So I'm going to oppose it now, but I certainly want to work with the gentleman in the future to see how we can make this work. I just don't think this legislation is the appropriate vehicle for such a change because of all these complicating factors.
Will the gentleman yield?
Yes.
I would like to work with the chairman. It's been 3 years, and it's been a lot of pain trying to see what's happening when we have the 2 systems here treating patients differently. What's hard for us here is that we don't get the benefit of dynamic scoring. So take mental health patients, for example, where these drugs are very fragile. And you could have a schizophrenic or a mental health patient. They all respond differently to different drugs. And if you're too restrictive, it can cause increased social costs, harm to individuals, family members, increased judicial costs. So I would agree with the chairman. There's a lot at stake here, and what the chairman just mentioned is why I was not successful in a House-Senate negotiation 3 years ago.
Well, I want you to succeed all the way through on this provision because I understand the consequences of it. Let me request of you that you withdraw the amendment. If we can figure out something now, we'll do it. But if not, I think we need to revisit this issue, revisit this whole issue of pharmaceutical coverage on Medicare and Medicaid. Yes.
In that spirit, to work with me so we can bring these programs together, I'll work with the chairman or work with Chairman Pallone to make this a reality. Based on that, I'll withdraw my amendment.
I thank the gentleman very much for his withdrawing the amendment. The amendment was withdrawn.